Thank you. I'm going to talk about outcomes in minority groups, drivers of disparity. My name is Greg Vidal. These are my disclosures. So it was Martin Luther King who said, of all forms of inequality, justice in health is the most shocking and inhumane. It's important for, at least in oncology, that every group of patients have similar outcomes, but that's not the reality. Cancer mortalities by racial and ethnic group has been different. So here we see on the left for men, the yellow bar, which is Black, green Asian, and we can see white in in purple. We see Black men as well as women have been having worse cancer mortality rates than other racial groups. When we look at the incidence versus mortality rate, we see non-Hispanic Blacks again have slightly higher incidence. That's all cancers, not specifically breast, which results in higher mortality rate. And we can see very similar high mortality rates in Latino, Asian Pacific Islanders doesn't have a high incidence, but the mortality rate is comparable, and that's for male and female. We've been doing well over the years in getting better treatment, better diagnosis. And so overall, the cancer death rate has reduced for most groups, but Black patients still remain on the top of the pile, doing worse in terms of outcome and mortality. This was for all comers, but when we look at specific types of cancers, we see the same thing, be it colorectal, lung, liver. Black patients continue to do worse compared to white patients, despite improvement in over the years in mortality rates. So why do we see cancer health disparities? And it's a multifactorial process. This starts all with racism and segregation, structural insecurities, and social determinants of health, which you can see there, all of which leads to cancer health disparities and health outcomes, adverse health outcomes. Where do we see the greatest geographic disparity in cancer mortality? You can see the red here, which is in the South. And that is for males as well as females, shown in dark blue. So we in the South are not doing well from a disparity perspective in cancer mortality rates. Why that happens, there are a number of reasons. One of them, this was a study that was done in Chicago, showed that Black patients versus white patients are less likely to have a pathologic complete response to chemotherapy. Why is that important? Pathologic complete response is a description of having all of the tumor be killed by chemotherapy. So when you go to surgery, so we give the chemotherapy before, when you go to surgery, you can find no disease. That end result usually portends a much better prognosis. We can see on the left here, in terms of overall survival, a survival probability, we see Black patients have worse survival probability, and on the right, again, PCR, pathologic complete response, was lower in the Black patients. We do have, in that particular cohort, the HER2 positive patients tended to have the biggest disparity, but we also see it in triple negative, which to the right, and the overall patient population. And we know pathologic complete response translates into survival. Here is for a triple negative cohort of patients that was presented by Siemens et al. At San Antonio, and I think since published, where based on the amount of disease that wasn't killed by chemotherapy that we find on pathology after neoadjuvant chemotherapy can prognosticate or predict your risk of recurrence, with the patients having what we call RCB3, higher disease, residual disease, having worse outcome. And in this measure, this was event-free survival. The result of this study that we talked about, as presented in San Antonio. The conclusion was that racial disparity in treatment was noted, and in that particular cohort, they did notice a delay in chemotherapy diagnosis for Black patients versus white patients. And there was also a decrease in alteration in cycles. So number of cycles received for all the 7 drugs, Black patients received significantly fewer cycles than white patients. And there are many reasons for that, one of which is tolerability and comorbidity, which we will talk about later. What is the impact of delay in chemotherapy? We know that delays in chemotherapy greater than 8 weeks result in worsening outcome. You can see the hazard ratio here in the red boxes. Anything greater than 1 suggests worse outcome. 1 is equivalent. Less than 1 is better outcomes. So at 9 weeks or greater, we see worsening outcomes when you have treatment delays. In this particular cohort, it was worse for patients who were triple negative, which we find a lot in Black patients or patients of color, high-grade disease, lymph node involvement, which is down here, or greater size tumor. We also noted that the population that tended to have more delay were the younger patients. Black patients tended to present more at a younger age than white patients in breast cancer, particularly. The uninsured or low insured, the Medicaid or no Medicaid patients, and then the patients who have low median income household. So there's a group of patients which are minority, low income with a socioeconomically disadvantaged patients are more likely to have delays in their therapy, and we show that delays in therapy can impact outcome. We at West looked at a group of our patients who were estrogen positive receiving chemotherapy and wanted to see whether their comorbidities coming in impacted their ability to tolerate chemotherapy and whether or not it had impact on overall being able to continue their therapy. And what we find is that Black patients were presenting for chemotherapy with higher comorbid conditions. And here we have them listed as general physical symptoms. They were more likely to get treatment side effects. They were more likely to complain of acute distress. The only symptom that didn't appear to be much more related to Black patients were despair. Now, when we look at those, the graphs here, ND is noted despair, ED expected despair, and the UD is what we didn't expect. So we expected the dark gray for, say, general physical symptom. That's what we expected. But we noted the white bar on top, so the UD is what was unexpected. So we can see for all of these different symptoms that Black patients were presenting really with more symptoms, which then translates into worse side effect therapy. We also looked at patients who were receiving endocrine therapy, adjuvant endocrine therapy in our very similar population, and did a post hoc analysis in a randomized controlled trial looking at a mobile app to see whether or not we could impact adherence. But overall, the findings, which was presented again and published in JAMA Network, showed that Black women tended to experience higher symptom burdens at baseline at 12 months follow-up. They had lower endocrine therapy adherence, which was attenuated after controlling for symptoms. So saying that symptoms was likely impacted the adherence. Black patients' lower adherence were explained by socio-demographical and clinical characteristics, as well as higher symptom burden. So if you were controlling for social and demographic conditions, comorbid conditions, then the adherence is actually similar, which means that these other factors are impacting patients' ability to stay on drug. We took a look at patients across the nation, almost 12,000 patients to see whether or not there was behavioral practices that also impacted outcome. What we know that is NGS, which is molecular profiling in this particular cohort was lung cancer, is an absolute necessary for selecting the right treatment for patients who were diagnosed with metastatic lung cancer. If you don't, there's data that suggests that if you don't wait for the NGS result and make your treatment selection based on NGS, those patients tended to have worse outcome. So we decided to look in a cohort of almost 9,000 white patients, 1,500 Black patients, and 500 Latino patients to see, one, whether there was a difference in timely testing of NGS, and then try to figure out why, on a more global level, we see this disparity. Firstly, we found that there was, in fact, lower timely testing for patients of color, be it Latinx or Black patients versus white patients. And this was when we look on the patient's level, the practice level, or the provider level, we saw the same differences. When we look at on a more global level where the problem might be coming from, we see that at the practice level, that when we're looking at patients, that is across practice, which is defined as practices that see more patients of color, are we seeing greater disparity in testing at that level versus within practice, which means that one practice have a behavior that is where lower NGS testing is done versus another practice. We see that at the practice level, there's sort of equivalent contribution of practices behaving differently, as well as patients who are of color are going to practices that generally don't do a lot of testing. But when we look on the provider level, this was very surprising to me. I thought that bias would be playing a larger role here. We find that really bias is playing a minimal role. Only 23 to 33% of physicians, are choosing to test more in their white patients than in their patients of color. However, most of the inequity that we're seeing is coming from the fact that patients of color, being Latinx or Black, are going to providers that generally don't test. So they don't test their white patients at much the same rate as they don't test the Black patients. So they just don't do testing, and that's something that we have to work on. So inequality is inequality sufficient to erase disparity in outcome? And this schematic here is showing us that no, we can strive for equality, meaning we all get the same things, but some in our community may require a little bit more to close some of that gap so we can get to the same outcome. A good example of that is this large trial that is now impacting how we treat our patients who have ER-positive, node-positive disease. This trial utilized an assay called the recurrence score assay to determine who should get chemotherapy in that group of hormone receptor positive patients with lymph node disease versus who shouldn't. They used the criteria of less than or 25 or less or greater than 25 to make a determination of chemotherapy. So if you had a recurrence score greater than 25, and that's been known from previous study, those patients got chemotherapy. The question is, if you were less than 25 and had lymph node involvement, was the addition of chemotherapy adding anything to the hormonal therapy? What we found was, and this was just for all patients, that for postmenopausal women, if you had less than 25, no difference with the addition of chemotherapy. For premenopausal patients, there was. But when we looked at the entire patient, so this was a very sterile environment of everybody getting similar treatment on a clinical trial, that Black patients were tended to do worse than white patients. So we had an assay that was doing the selection. The chemotherapy was pretty much the same, and patients were treated in the sterile environment, yet Black patients were doing worse. So even if they got equality there, we still had worse outcome. And that was both for invasive disease and distant recurrent-free survival. What was some of the differences in patients by race? We saw that Black patients tended to have a higher BMI. Could that play a role? Well, looking through this data, we also saw that there was a little bit difference in the type of chemotherapy that the Black patients got versus white patients, where white patients tended to get more anthracycline-based treatment. Did that play a role? Well, the authors did try to control for that in a multivariable Cox regression analysis. And what I'm showing here by race for BMI, that when they adjusted for treatment arm, menopausal status, age, grade, and BMI, although those numbers went down a little bit in terms of the hazard for BMI, it was still greater. Black patients were still doing worse. So those differences, minor differences in terms of treatment and BMI really wasn't the greatest driver of the worsened outcome that we saw. Now, there was a second study presented at ASCO last year that used the group of patients from this study that I just talked about, and another study called TAILOR-RX, which used patients with lymph node negative and combined them so that we have a greater population of Black and white patients, and then looked through their data set and see whether or not patients were having worsened outcomes. I will summarize to show you the subgroup analysis. So in patients who were greater than 26 or higher on the bottom here, regardless of whether or not, so all of these patients got chemotherapy, whether or not you're Black, white, Hispanic, or Asian, patients generally did well. So on the left is better survival than white. We see that for Black and white patients, it was almost equal. The Asian and Pacific Islanders were doing a little bit better. But if you were less than 26, meaning those patients didn't get chemotherapy and they only got hormonal therapy, Black patients were doing significantly worse than the rest of the population. It certainly brings to mind that, are we using the right sort of tool to determine who should get chemotherapy in the Black patient? Is recurrence score not the appropriate tool to determine for risk stratification for Black patients? And that's certainly, we've seen this in other places and in other publications. We at West looked through our data set. We had a group of almost 163 patients who had both MammoPrint, which is another risk stratifying tool on the market, versus the recurrence score, and to see whether or not there was a difference in terms of concordance, and those, they're not very concordant. There's not a lot of concordance between them in terms of the numbers that they give for risk stratification. But more than anything else, what we saw is that for recurrence score, for the average patients, the Black versus white patients, the scores were very similar based on biology. But when we look at MammoPrint, MammoPrint was actually giving Black patients a slightly higher score than they were giving white patients, which begs the question, especially when we saw the results that I just published, talked about earlier. Would MammoPrint be a better risk stratifying tool for patients of color versus recurrence score? This is certainly provocative and requires further investigation. So erasing disparity. So we talked about inequality and whether equality is the answer. It's not all the answer. Equity is what we really should be striving for. So we give you and we treat you based on your particular characteristics and criteria, with the outcome being we all have the same and similar great outcome. So how do we achieve equity? Some of the examples here are some highly effective tools are prevention and screening. Make sure that patients of color as well as white patients get very similar prevention and screening. Make sure that once you screen, you can get your treatment. Health insurance coverage, and then access and participation in clinical trials are very important because that's where the newer tools for fighting cancers are first given to patients. Here we see in terms of screening within our market here at Memphis for breast and colon cancer, we see really, if we look on the right here, African Americans in blue, Europeans in green, and Hispanics in red. For colon cancer screening, there's very similar screening numbers between African Americans and white, with Hispanics a little bit lower. For colorectal, again, it's less. For breast and mammographic screening, we have less screening than Hispanics or Caucasian, and whether or not that impacts our outcome, we just showed that those are very important tools when we're trying to close disparity gaps in outcomes. We also know that early diagnosis, which is what screening fully impacts, the diagnose when you get the stage at which you get treated. The earlier we diagnose you, the earlier stage, the better your survival. And this is what this is showing here. Distant metastasis is in green, blue is regional, growth to the lymph nodes, and local tumors is just in, say, in this particular case, just in the breast, for example, or in the local, in the area, in the tissue of origin. We see if you have localized tumors, they have better outcomes, 5-year survival, than if you have regional lymph node involvement, which would mean a later stage, or distant involvement, which is an even later stage. So screening is important, and we need to make sure that all groups get equally screened in a timely manner. We also see that insurance coverage matters. Here, what we're seeing here is a graph that shows the outcome based on outcome based on insurance coverage. This is all, the top group is Medicare, coverage due to cost. We see there's greater delays, a disparity in outcome for the uninsured by age. In the less than 64, we don't see that as much in all of the group in greater than 65 because most of the greater than 65 have at least Medicare coverage. When we look at, particularly for colorectal screening, we see the uninsured or Medicaid type insurance for the younger patients tend to have greater disparity in access. And then if the very similar numbers are seen with breast cancer screening, suggesting your type of insurance or lack of insurance also impacts screening. So this is a cohort of colorectal cancer. And in these patients, this graph specifically talks about disparity in survival for uninsured colorectal cancer versus insured. We see that, again, we talked about earlier stage, higher 5-year survival, which is generally accepted. But here what we're seeing is for stage 1, which should have the best 5-year survival, if you have private insurance, you're doing well. But if you present with stage 1 and uninsured, you're actually doing worse than if you had private insurance with a higher stage of private insurance. So insurance coverage absolutely matters in overall outcome. One of the important tool is sort of coverage or governmental-based coverage. We all know about the Affordable Care Act that was enacted that helped bring millions of patients onto coverage, but some states did enact the Affordable Care Act, whereas some did not. Let's see the differences in outcome. So here you have a graph, of states where Medicaid were expanded versus those where Medicaid was not. The blue shows highlight states who adopted Medicaid expansion on the Affordable Care Act, and the ones in, I guess, orange did not. When we overlay that over where we see the greatest disparity in cancer mortality, we see that the states that didn't expand Medicaid are sort of the very same states where we see greater disparity in mortality for both males and females. What was the overall impact of the Affordable Care Act and expansion of Medicaid on insurance coverage? Here we see again graph on top, expanded Medicaid in some of the states that did versus on the bottom states that didn't. For Black patients, which is this lighter orange, and white patients in blue, we saw an overall decrease in uninsured rate for all patients, with Black patients having a greater decrease in being uninsured. When for the states that impacted Medicaid, where we didn't see that much change in the states that did not. We just showed data that coverage is important in closing disparity. So then we are the states that did not are possibly doing a disservice to their overall population, but it seems like the Black patients may be the ones who are impacted the most. This was data presented by Dr. Chavez at San Antonio, just giving an example of the impact of Medicaid expansion on chemotherapy delays. What we see there is a group of patients pre-expansion that there was a delta, about 8.7% difference in chemotherapy delays for Black versus white patients, which was almost erased post-expansion, suggesting, again, insurance coverage does impact delay, which I showed earlier, which could impact outcome. Clinical trial participation. What we see is, as I mentioned earlier, one of the important aspects of closing the disparities, participating in clinical trial. Here we see high-income patients are participating at a much greater rate on clinical trials than low-income, middle, and upper income. And so income also may impact outcome. So in conclusion, disparity in care and outcome exist. Cancer survival rates are improving, but disparities still exist based on ethnic or racial, geographic, and insurance status. Time to treatment and baseline symptoms are important contributors of disparity and cancer outcome. We must take into consideration patient baseline symptoms to select appropriate regimen, provide better counseling and management strategies to improve tolerance, because it does impact patients' ability to tolerate their treatment. And disparity in outcome care will continue to exist if disparate access to care still persists. Again, in erasing disparity, we ultimately are striving for justice. In all aspects of life, which would help erase health disparities. Thank you very much.